Okay, welcome back everyone to the next session. This one focused on atrial fibrillation and in particular ablation. My name is Steve Wilton from the University of Calgary, and I'll let my co-chairs introduce themselves as well.
Good morning, everyone. A pleasure to be here and see everyone to continue with our morning. I'm Pablo Neri from the University of Ottawa.
Good morning, I'm Rupi Sandhu. I'm pretty much everywhere. So I'm at Cedars-Sinai right now, but have an affiliation at the University of Alberta.
So we'd like to kick off the AF ablation session. We'd like to thank the organizers once again for a great meeting. It is doing our first session this morning. We'll check if Atul is online. Steve?
Yep. I'm online.
Okay, great. So, Atul, it's a pleasure to have you. Atul Verma needs no introduction. As Director of Cardiology from McGill University Health Center and McGill University of Montreal. So Atul is going to be talking to us this morning about new technologies with focus on pulse-field ablation. So Atul, it's our pleasure to have you. Can you hear as well?
Yeah, great. Thanks very much. Is my audio okay for you guys?
Yeah, it's good.
It is
and
great.
You see the slides?
We do.
Okay, great. Fantastic. So sorry I couldn't be with you all there in person. Banff would have been really nice at this time of year, but I don't normally dress like this on the weekends. I'm on call this weekend for CCU, and I asked the chief of cardiology to switch me, but he said no. So let's talk about PFA and new technologies. Here are my disclosures. So what am I going to cover? So I'm going to briefly, I can't help but talk a little bit about the ADVENT trial and what it means for PFA and my take on it. I'm going to then talk a little bit about combined thermal and PFA technologies. And finally, how do we know when we're done ablating with PFA? So basically, going into ADVENT, everyone was super excited about PFA. It was going to have better safety. It was going to have better efficiency. A lot of people were saying it was going to have better efficacy. It was going to cure global warming. I mean, everyone thought everything about PFA. And of course, the ADVENT trial was presented at ESC, published in New England. Very good study. And it showed that basically the Kaplan-Meier curves for efficacy were completely superimposed. I mean, it couldn't have been more superimposed than this, showing that the efficacy of PFA was no better than cryo and RF. Now, there were a lot of people who expressed surprise at this, but in fact, it really should not have been surprising, because at the end of the day, depth matters. And I think tissue depth is directly correlated to 12-month outcome. And these bipolar biphasic PFA systems were designed to deliver lesion depths of about 3 to 4 millimeters, which is no better than what cryoballoon or RF gives you. And even though Vivek Reddy had shown this beautiful publication where he was getting 96% durable PV isolation at 3-month remap with PFA, everyone forgot his previous study only 6 years earlier, where he showed 91% durable PVI at a 3-month mapping study with cryoballoon. So in fact, we should have expected that the results were going to be exactly the same. Some people were a little surprised by the safety issues. There was a couple of tamponades, a stroke, and a death in the PFA group. And this is where depth doesn't matter, but size matters. This is a very, very large catheter. 31 millimeters is the small size, 35 millimeters is the large size. The sheath is huge at 16.8 French. And the one depth in the study was due to entrapment of the catheter in the left atrial appendage. And when they pulled it out, they lacerated the appendage, and unfortunately, the patient died. The operators were all also novice users. And so when you've got a big honking thing in the left atrium, it perhaps isn't surprising that you're going to be in for some complications. The efficiency was definitely there. The procedure time was 20 minutes less. And I think, this included a 20-minute waiting period. Again, this may have to do with the learning curve and the fact that most of the operators had very, very little experience. A lot was made about this significant secondary endpoint in the cross-sectional area of the pulmonary veins. They showed that compared to thermal, there was very little change in the pulmonary vein cross-sectional area, whereas with thermal energies, there was about a 12% change. Is it meaningful? No, it's not meaningful. I've shown below a beautiful study showing that if you just change from your left side to your right side, you can actually get a 30% change in the cross-sectional area of the pulmonary veins. So 12% versus 1% is basically 0 versus 0. So my comments, this was the first ever use of the system by novice operators. It is a first generation PFA system, so I think it has to be congratulated for going up against thermal, which has had 20 years to perfect itself. But I think before we, nail the coffin of the PFA, we have to consider what's the burden of evidence from all the various different systems. And I think there's beyond a shadow of a doubt the fact that the esophagus, phrenic nerve, PV stenosis is safer, if not completely safe with PFA. There has been one permanent phrenic nerve palsy reported out of more than 3,000 cases. And the incidence of cerebral silent emboli are very, very small. If you look across at other trials, this was the Pulse AF trial using a smaller catheter system. There were absolutely no evidence of the SIMA death or other complications that we noted with the other system, and certainly no esophageal or pulmonary vein stenosis found. And this is the BioSense study where, again, it was incredibly safe. So I think safety is without a doubt there. Efficiency also, if we look at the left atrial dwell time in both Advent and Pulse AF, it was under an hour, and that included a 20-minute waiting period. If we look at the total amount of energy delivered, it's very, very short. And if you look at the procedure times, this is from the AFERA publication, the PFPF cohort had about a 22-minute transpire ablation time. And if we look at more experienced users with the AFERA pulse system, we're getting down to procedure times of about 40 minutes. So I think better safety, yes, better efficiency, yes, but no one should have expected miracles with better efficacy. And if we look across the board again at Pulse AF, about 70% success in paroxysmal atrial fibrillation. The VeriPulse system, about 70% success in paroxysmal atrial fibrillation. Advent was about 70% success in paroxysmal atrial fibrillation. It's all the same. Okay, so let's move to why we might combine PF with thermal energy. Is there any point to this? And this is an example of combining pulse field with cryoablation. And basically, the idea here is really to increase tissue depth. Because if we take the current pulse field systems and we simply dial up the voltage to try and get more depth, all of the current systems are right at the thermal threshold. So that means if you dial it up any further, it's RF energy, it's burning the tissue. And that's pointless because we already have that. So why would you freeze and then deliver PFA? Well, this is a tale of two impedances, because here with freezing, you actually increase the impedance of the tissue, but the ice also acts as an insulator, preventing loss of PF into the bloodstream. And so you actually get an amplification of the pulse field in the frozen tissue versus the ice on the catheter, despite the fact that the tissue has more impedance. Furthermore, because the ice is insulating the PF from going elsewhere into the body, you don't get musculoskeletal system. You don't get microbubble formation, which is due to electrolysis of the blood. And therefore, you can actually dial up the voltage because you're not going to get incidental heating, skeletal, musculoskeletal stimulation, or microbubbles. So you can actually deliver more PF into frozen tissue. And that potentially will give you deeper lesions. And in fact, when we looked at this at a preclinical model, we in fact found that you could increase the lesion depth from about 4 or 5 millimeters with cryo alone and going up PFA alone, and going up all the way to about 8 millimeters in depth with combined cryo PF. So if you go back to my earlier statement that tissue depth equals 12 months success rate, by getting more transmural more reliably in different parts of the atrium and eventually perhaps in the ventricle, we need tissue depths that exceed that 3, 4, 5 millimeter depth threshold. What about combining RF with PFA? So here, the impedance story is very different. So instead of increasing the impedance of the tissue, we are now decreasing the impedance of the tissue by pre-treating it with radiofrequency. And you know this because watching for that impedance drop is one of your endpoints for radiofrequency ablation. Well, the great thing is that, yes, you are causing edema with subsufficient RF. You are decreasing the impedance of the tissue. And both of these things are excellent for PFA. You want a watery tissue with lots of electrolytes in it to conduct the electrical impulses. And you want a lower impedance system to conduct the electrical impulses. So in fact, when you deliver PFA after subthreshold RF, you can actually push the PFA much deeper than if you either had one or the other alone. So this is an example of RF of 50 watts for 10 seconds. So a fairly good dose of RF. But then we delivered 12 pulses of RFA in a monopolar fashion. And you can see here that the PFA is extending well beyond the limits of the RF. And you probably could go even lower with that RF and still get that penetration of PF. So when you think about systems that are combining RF and PF, there is the potential to be able to drive deeper tissue depth. The problem, of course, is that there is a danger because let's say you do PF first and then you deliver RF. Well, the PF also decreases the impedance of the tissue. So when you then deliver RF, the RF is actually going to extend deeper than the PF lesion. Now, maybe this is fine for the ventricle, but if the esophagus is right there, you'd rather have the PF going deeper so as not to cause esophageal injury rather than the RF going deeper, which of course can cause esophageal injury. So it just shows that if you're going to use a combined system, and you're going to start with PF and then touch up with RF, there may be some potential dangers to that as opposed to doing it the other way around. And I'll be presenting some further data on this in the upcoming weeks and months. The next thing, of course, is can we bring the electro back to electrophysiology? We are, after all, people who interpret electrograms, but bipolar electrograms basically become useless in determining chronic lesion development in PFA because with even one application, the electrograms are gone. But unipolar electrograms may actually be very interesting because post-PFA, we see interesting patterns of ST elevation. We see changes in the RS amplitude, and we also see changes in the slope of the electrogram. And so, in fact, Antoni Arbivora's group in Barcelona showed that depending on how far away from the lesion you look at this, whether 5 minutes, 10 minutes, or 15 minutes afterwards, you can go back and interrogate the unipolar electrograms and actually predict whether your lesion is irreversible versus reversible. And that'd be very interesting if we can bring electrocardiography and intracardiac electrograms back to electrophysiology. And then finally, in the last minute, I just want to talk a little bit about other ways that we can tell that we are done with PFA. And as it turns out, PFA causes changes in the optical properties of myocardial tissue by breaking down the pores and causing a disconnect in some of the actin and myosin filaments. And so this was a research thesis, master's thesis done by Dr. Maria Terry-Cabras, who is now going to be a staff VP at Sunnybrook. And what we had was a PFA catheter system where we integrated optical sensors into the end of the catheter. And as it turns out, very interestingly, we can actually see birefringence drop by a certain amount after the application of PFA. And it turns out that a drop in 20% of optical birefringence may be important to predicting chronic lesions. So acutely, when we explanted the heart, what was kind of interesting is as we dragged the catheter over the lesion to normal tissue, we saw a change in birefringence. But when we took that heart at 8 weeks and we actually had histology to prove whether there was a transmural lesion or not, we still found those optical differences by dragging the catheter over those different parts. So there may be both electrogram as well as optical methods for determining whether or not we are done with PFA. And we actually found that the system had an accuracy of about 91% in predicting permanent transmural lesions. So with that, I'm going to conclude by saying that the ADVENT results should have been expected, based at least on efficacy, and the size was a big deal in terms of the complications. I do think that the trial gives a realistic picture of a first-gen PFA technology versus a 20-year technology in thermal ablation. Combined thermal and PFA is very interesting, but is currently a science project. And new ways to assess completeness of PFA lesions, I think, are going to be very, very important. Thank you very much.
So if you have questions, you can go up to the mic and ask them. And while people are coming up, maybe I'll start with one. So Atul, you started with the three concepts that we all want to optimize with AF ablation, so efficiency, efficacy, and safety. And I guess I'm just looking for your opinion. Do you think that we've reached a point where we're at the trade-offs between those three as we advance with technology, or do you think there's room to improve all three still?
Yeah, it's a good question. So I think safety with PFA is about as good as it gets. I don't think we're going to see further enhancements on that. I think you will hear in upcoming times of newer PFA technologies that are quite capable of doing subclinical damage to the esophagus. But one of the nice things about not destroying the extracellular matrix is that the esophagus can start to heal itself within 2 or 3 days after such an insult. But that shows that how, as you start to push the power of this system, you're crossing that safety threshold. And right now, already as it is, many of these systems are at that thermal threshold. Efficiency, I think as people get better, the efficiency is going to get better and better. I don't think there's much to be gained. I'm not sure why we need to do a procedure in 20 minutes rather than 30 minutes. I mean, it's kind of becoming a little bit ridiculous. So yeah, I do think there are going to be trade-offs. And, if you really want to push depth, the question is, do you want to combine it with thermal, or do you go back to point by point? Because as it turns out, for the same amount of voltage and the same amount of current, if you use a point by point catheter versus a big flower or circle or whatever, you actually get more depth, less temperature, and more bang for your buck, and you still preserve the safety. So when people say point by point PFA, what's the point? The answer is it'll get around some of the limitations of these bigger devices.
Thank you. All right, looks like no more questions, so we'll move on to our main event here for this session.
So it's my pleasure to introduce the next session that I simply refer as to the debate. So in the history of sports, there's arguably been one epic battle of the sexes, that of the exhibition tennis match between Billie Jean King and Bobby Riggs that occurred on September 20th, 1973. And of course, Billie Jean King won in straight sets, not only earning bragging rights, but a winner-take-all $100,000 prize. Almost 50 years to the day, we are here to witness what I anticipate will be another epic battle of the sexes, this on the timing of AF ablation. So this debate will consist of two 15-minute arguments, one on the Fix the Risk Factors First by Dr. Prakash, and then Catheter Ablation, Sooner is Better by Dr. Andrade, followed by 5 minutes of rebuttal. So let the games begin. Gentlemen first.
I feel like Rupi spent too much time in LA with her big poofy shoulders.
My animation should be better. I need to spend more time.
Your Photoshop skills are terrible. Okay, so I have limited time here, so I have to burn through this as fast as I can. All right, so to frame this debate, I thought let's have a case, and I'll try and work through some of these points on the case. So this is a 58-year-old gentleman, because men get atrial fibrillation younger. He's got hypertension, sleep apnea, and obesity. Remember, those comorbidities, we'll come back to them. And he's now a year from his diagnosis. He has 3 episodes a month. He has had a previous cardioversion, and subjectively and objectively, he has quality of life impairments. And those points are also important. So the outline for my side of the debate is this whole thing is a logical fallacy and it's pointless. The second part is, what are you going to offer this guy if he's in your office if you don't offer him ablation? And then I'll start giving you evidence after that. So why do I say it's a logical fallacy? Oh no. So this is the book of logical fallacies. I love this book. It takes you through them all and explains them and gives examples, and you can deconstruct everyone's bad arguments. So this is a false dilemma. So at no point in any place are we going to just do one thing and forget about the other, right? Risk factor management is equally important as arrhythmia management, is equally as important as stroke prevention. So no one's going to ignore the risk factors and ablate and send them on their way, or at least you should not, because then you're just a cardiac surgeon. For us, I think it is in partnership. It's not an either-or perspective. Okay, so now that we've put that behind, so what are you going to do instead of ablation? We have pills and we have lifestyle modification. So we'll start with lifestyle modification. So if this person comes to your office, you say, well, no, I'm not going to ablate you because you're fat and you have sleep apnea. So get rid of your fat and take your CPAP, and then you can come back and see me in 6 months. In the guidelines, I believe this. We say that there are 6 or multiple risk factors that need to be modified. We've given clear guidance about how those should be modified. I personally believe it is very important to treat the whole patient and modify those things. And why do I believe that? Well, there's a bunch of studies that have come out, predominantly out of Adelaide, and they've shown us that management of body weight, exercise, risk factors, all of those things are very, very important. And Prash is my friend, and Prash recently took me out to some wineries in Australia. So clearly I have a fondness for him and his evidence. But it's garbage, right? So the problem with all this is it's observational data. And so observational data is limited by something called the healthy adherer effect. And what that means is someone who will adhere to a therapy is going to have a better outcome than someone who will not. And so if you take a bunch of patients and you say you're on the wait list for ablation, as was in this study, and you can either go lose weight or not, and then we'll divide you based on that, or you can go exercise or not, and we'll divide you based on that. Those people that do those things are going to do better. Now, what evidence do I have of this? This is the best evidence of that. So this is a bunch of studies, and what they showed in these studies is if you adhered to placebo, you did better than if you did not. So this is nothing about any therapeutic intervention. This is the placebo arm of randomized trials. And if you were in the placebo arm and you adhered to your placebo, your survival was better, right? So people who are conscious of their risk factors, who will lose weight, who will exercise, who will not smoke, who will not drink too much alcohol, they will do better. And so in any observational data about lifestyle, that will look great. It's not randomized. It is not a type of data we can use to make a therapeutic decision. So then, that is the outcome of what they've said in their studies. This is our nice table, and this is what we adapted into the AF guidelines because I believe it to be true, but there's just no evidence to say that it is. So our patient had sleep apnea. So what randomized evidence do we have about sleep apnea? CPAP does absolutely nothing to change cardiovascular events, New England paper. What about high blood pressure? Dr. Prakash, her own study, managing blood pressure does not change anything. So randomized evidence is telling us there's nothing specifically there that will make things better. So then what's our other alternative? We offer a pill to our patients. We say, okay, well, you come to your office, you have symptomatic AF, here's an antiarrhythmic drug. In a randomized trial, less than a third of patients will maintain sinus at a year. So how efficacious are they? Not very. What are the risks of these therapies? Well, in network meta-analyses against placebo, amiodarone is associated with 2.5 increased risk of death. Sotalol, more than 4-fold increased risk of death. So these medications have significant toxicities. What about in our studies where we've compared it to ablation? Ablation works much better at 1 year. It works much better at 3 years. This is robust loop recorder data, much more efficacious therapy in an unbiased cohort. What about quality of life? Again, robust improvements in quality of life at 3 years, robust reductions in healthcare utilization on follow-up. So if we're saying, well, we have ablation and we have drugs, drugs are not going to be good enough. You say, okay, well, invasive procedures are risky. We're potentially harming our patients by doing these interventions. In our 1-year follow-up, the risk was actually a wash. No worse significant adverse events at a year. And because you can follow these patients for longer than a year, that risk actually decreases with time because you amortize it. You take all your risk right up front with your ablation, and then you have no risk the longer you follow these people. But if you're giving them a drug and saying, spend 3 years losing weight and then come back and see me, over those 3 years, those patients can be twice as likely to have had a serious adverse event while waiting. We know that our current ablation procedures are very safe. Overall risk of major complications based on a contemporary ablation procedure is about 2.4%, with half of that being groin complications. Strokes, much less than 0.2%. Tamponade, less than 0.8%. But as we've evolved these procedures in the last 5 years, those risks have significantly decreased relative to the 5 years preceding that. So major complications have gone from 3% down to under 2%. Groin complications are fairly static, but tamponade's gone from 1% to 0.6%. Stroke has gone from 0.2% to 0.15%. Our procedures are getting safer. And so the relative risk benefit is pushing further and further towards an invasive intervention being the preferred first strategy. Okay, so then this part I'm just going to quickly go through. I know I don't have a lot of time. So the point here that I wanted to make is that, okay, so now we have this guy in our office. We admit that this is a false dichotomy and really we're going to provide comprehensive care. In our options between drugs and ablation, drugs are going to perform less well than ablation. But you could make the argument, okay, well, so lose some weight and come back to see me in a few months, and then we'll do your procedure. The problem is that AFib is not a static disease, and delaying a year to do the intervention is not necessarily going to benefit anyone. We know that when you do PVI for paroxysmal AF, the success is greater than when you do it for persistent AFib. A different way of looking at this is the concept of the diagnosis to ablation time, and Derek Chu, if he's here, has done great work on this. And so what diagnosis to ablation time is the time from when you're first noted to have AFib through to when you get a more definitive intervention. And so if it takes you longer than a year to get your ablation, your success is lower because the disease has festered in the background for that year. Importantly, after the intervention, your risk of all-cause hospitalization goes up. So it's not just that the success is lower, it's that there's a bad outcome that comes with it. Utah data looking at this shows that it's sort of a dose-response effect. The longer you wait, the more likely you're going to have heart failure hospitalization. The longer you wait, the more likely you're going to have a thromboembolic event. So delaying an intervention for some arbitrary reason is not going to benefit those patients. The other problem is as I mentioned, it's not a static disease. And so as you have these patients and you wait a year, so this is Ontario data looking at the things that happened to people while they were on the wait list. And in Ontario, the wait list was about a year to have their ablation. You can see 11% of patients got hospitalized in that year. 40% went to the emergency room. So again, if you say, well, let's work on your weight or get your blood pressure under control, and then we'll consider it, in that time that you're waiting and to consider it, the patients are going to continue to present to the emerge, continue to get in the hospital. And in the same sort of Ontario data set, about 10% progressed to persistent AFib. And that was very consistent with some data we presented at ESC this year, is that in the 70 days or so that people were waiting to have their ablation, the rate of progression was much, much, much higher than what happened after they had their ablation. So the disease is not a stagnant state. It doesn't wait for you to make your intervention. The disease is continuing to fester along until you do something about it. And why does that matter? Well, persistent AFib is bad. It's higher rates of death, higher rates of stroke, higher rates of heart failure hospitalization, higher rates of complications when you finally get around to doing the ablation in terms of emergency room after the procedure, and even in terms of mortality. Persistent AFib is a bad animal that you want to avoid. So why not treat the disease? I think I'm at the end, so I'll just quickly go through this. We know that drugs don't modify the disease in terms of electrical or structural remodeling. So this is data out of Australia. They took patients with high-burden paroxysmal AFib, compared them to patients without AFib. So patients without AFib are the red lines on these graphs. So that's no AFib. Just keep that as your base comparator. Your dark blue line is an antiarrhythmic drug-treated patient. Your light blue line is an ablation-treated patient. So having AFib is the blue lines, and at the left side of the graph at baseline, these lines are different from the red line. If you got a drug, you continue to get more different. You got worse over the year of follow-up. But if you had the light blue line, which is ablation, you came back towards patients who didn't have AFib. So something about our intervention with ablation changes the disease, and whether it's isolation, reentry modification, autonomic modification, there's lots of different mechanisms where ablation can work. Drugs really at best could handle calcium abnormalities, so class 1Cs or ion channel dysfunctions, potassium channels, for example, but they're not changing anything about the disease underlying it. And so we've shown, again, Canadian data here, cross-country data, that randomization to antiarrhythmic drugs is associated with a higher rate of developing persistent AFib on follow-up compared to having that initial ablation procedure. So what we do works well at changing that disease trajectory. When we wait to do that, all we're doing is allowing the disease to become more advanced, have more complications and more problems by the time we finally get around to it. And so there's no value to the patient to waiting, and there's no evidence that anything that's being done in that time that's waiting is actually changing anything. So for my part of the summary, the whole debate's a logical fallacy. We know that drugs are inferior to ablation. We have very limited randomized evidence that lifestyle intervention does anything beneficial, and absolutely no evidence that it replaces the benefit of ablation. If you then are committed to ablation, just do it. There's no reason to wait on it, because if you wait on it, it's not going to work as well, and it's going to be associated with bad things. Thank you.
All right, thank you very much. Thanks so much for inviting me here to speak, and to Dr. Montesser for organizing this great meeting. It's a great venue, and it's great to see everybody here. And I also have the pleasure of debating Dr. Andrade, who is a formidable opponent for sure, and we'll see how we go here today. You know, I agree with many of the points Dr. Andrade has raised, but let's talk a little bit about some things that I think are very important in terms of the atrium and atrial fibrillation and how risk factors fit into this whole thing. And I've asked Rupi to keep me on time because I have a lot of things to say about this, and I can go over, so we'll try to keep it going. These are my disclosures. Okay, so first let's just outline the scope of the problem. We've heard a little bit from Dr. Andrade about this already, but the first thing is that 95% of patients have some type of identifiable risk factor at the time of AF diagnosis and presentation, and that's data from Jeff Healy's study on the RELY AF registry, where he looked at 15,000 patients globally and identified risk factors in those patients who presented with AF in the emergency department. So 95% of patients have a risk factor. 300,000 patients with AF in Canada at any one time, that's the prevalence. And 75,000 of which have significant symptoms based on data looking at ambulatory patients with atrial fibrillation. You know, that's probably the number that have significant symptoms warranting some type of rhythm control. So we're doing about 2,500 AF ablations annually. Maybe that's a bit higher. That's data from our EP registry that Eugene Crystal has done a few times. And so the question is, how do we handle all these patients that we're going to ablate? I mean, I think we're just going to crash and burn on this issue, and that's really one of the main points that I want to make about the ablation story, is that we have this large volume of patients with atrial fibrillation with a lot of underlying issues that we need to address. So we really don't want to go into the crash and burn scenario, which is where our medical system is heading anyway, unfortunately. Okay, so I start with a case as well. It's very similar to the case that Dr. Andrade presented. 50-year-old gentleman with a new diagnosis of atrial fibrillation, multiple risk factors: smoking, binge drinking, hypertension, snores at night, doesn't sleep well, and so on. I think we know the drill, and someone like this might look like that. This, not saying that he has these issues, but you never know. But this is Dr. Popone, who brought us ablation a long time ago in 2005 and really set the stage for our circumferential isolation, so we owe that to him. But we have multiple options for this gentleman, and I think that most people would pick option number 4 there just very quickly. And now we have a second case. So the second case is different. This is a 50-year-old who's fit, well, but plagued with recurrent paroxysmal AF. No risk factors, not obese, on flecainide and metoprolol, but still has a lack of good control. Anyway, this patient was lost to follow-up for a few months and ended up seeing their family doctor because they couldn't get in to see their EP, and ended up being diagnosed with severe sleep apnea. Was treated with CPAP and no AF episodes. And so this patient might look like this, doesn't really look like the bill. Sorry, Jason, I don't mean to say that you have sleep apnea, but you're thin, so I put your picture up because of that. The point being that there are issues that happen, things that happen to patients' atria that are not necessarily related to the pulmonary veins, and we have to keep those in mind. And so this is what I always come back to, and this is a very important schema representing AF mechanisms. We're all familiar with this. It's a review for everybody, but we have to think about the fact that the atrium, yes, there are triggers, and the pulmonary vein, that was proven by Dr. Hassegair back in the 90s, and we understand that completely, and that's absolutely critical to our triggering of atrial fibrillation, but there is the substrate, and the substrate, Dr. Andrade suggested that maybe ablation can change that to some extent, but that's, very very little. There's a lot more to the substrate in terms of atrial fibrosis, in terms of the atrial electrophysiologic properties that we need to keep in mind that help with maintenance of atrial fibrillation. And so it's the combined sort of things that put atrial fibrillation together there. And I believe that risk factor modification really does identify and treat the substrate, where ablation is more likely to affect the trigger, somewhat the substrate. And so we talked about the RELI-AF registry and this concept of progression of disease over time. I think Dr. Andrade set the stage very nicely for that. But the issue is that what is the pathophysiology that drives the disease? It's not just the triggers that from the pulmonary veins or the ectopic extra pulmonary vein triggers and so on, but it's the fibrosis and the inflammation that's underlying that is present as part of the risk factors that we see in patients with atrial fibrillation. You can see this schema, which we're all, again, familiar with in terms of that. And we know already about the worsening MACE that happens in patients with the risk factors compared to no risk factors. And so our guidelines have done an excellent job of outlining these risk factors. We know that there are conventional risk factors, which we're all familiar with in this table, emerging risk factors and less established risk factors, but many of these are modifiable. And so there are many things that we can do to make the patient better with their AF before we even think about ablation. And so ablation is definitely part of what we're going to be offering patients with symptomatic atrial fibrillation, but there's much more to offer there, and that shows it nicely. Now, this study was a randomized trial. This is one of the only randomized trials out there on risk factor modification, again, out of Adelaide. And this demonstrated that there is a reduction in atrial fibrillation in patients who followed risk factor modification with obesity. And so the risk of new onset atrial fibrillation was reduced in patients who were less overweight. As we've already seen, the SMAC-AF trial was negative in terms of aggressively treating blood pressure. But one of the things that we did find within this study was interesting. It was a small study. It was 180 patients, but we did find an interesting interaction. That was statistically significant, and hard to know what to make of it. But the patients who had a better upstream blood pressure before they got into the study had a almost better response with ablation and with aggressive therapy than the patients who were not well controlled. So you wonder if we just need to be more upstream with our treatments for these problems than we currently are doing. This study was 3 months prior to the ablation to get your blood pressure under control, and perhaps that just wasn't enough. The other issues in Canada, our risk factor modification is so good in our general population, particularly hypertension, that it was hard to do a study in Canada on this problem because patients are quite well controlled. Other studies using renal denervation have shown a major improvement with renal denervation and pulmonary vein isolation, but again, the blood pressure drop was significant with patients not well controlled before getting into the study, with blood pressures in the order of 160 compared to our patients in Canada, where their blood pressures getting into the study were 140. And a target of 130 is where they got to. Another study that we didn't talk about already is the SORT-AF study, and this again speaks to the timing of affecting risk factors prior to ablation. And the SORT-AF study randomized 133 patients to an intensive weight loss program compared to standard of care. The BMI reduction was modest. It really wasn't very high, and so that was one of the criticisms of the study. As you can see, it was completely negative. AF burden decreased in both groups, but there was no difference between the groups. So again, not upstream enough potentially, and not enough weight loss were the criticisms there. And we've heard about the legacy study. And then the LEAF trial was a study that was used liraglutide in patients with atrial fibrillation. And there was a portion of that study presented at CHRS last year that demonstrated that those who had a 5% 5.6% weight loss had an 88% freedom from AF compared to those who had weight gain, a 0.2% weight gain, and at 61% freedom from AF. So again, more data suggesting that weight loss is part of the whole story. The RACE-3 trial was a positive study, a randomized trial looking at a mishmash of intervention using aggressive heart failure therapy as well as cardiac rehabilitation. It was upstream therapy prior to undergoing a cardioversion and showed a reduction in atrial fibrillation in patients at 1 year on a Holter monitor. And then finally, the alcohol story continues to build, and it is again data out of Australia showing a significant reduction in atrial fibrillation that was sustained with absence of alcohol. Which is interesting because we were pushing alcohol a fair bit yesterday, so hopefully nobody had AF today. But, from the Australian standpoint, they are big drinkers, apparently, I've been told from our Australian fellows who are with us right now. And so major difference there. So we know that there are many other things, and there was no ablation in this trial. This was just abstinence from alcohol, so significant reduction. And then the sleep apnea story continues to build. And again, we've got to think about the pathophysiology of what's happening when a patient has sleep apnea. The effects on the atrium, the left atrium itself, the increased left atrial pressure, the change in the substrate with the sleep apnea, not to mention what's happening with obesity itself. And so all of this to say that we can definitely affect the substrate for atrial fibrillation by modifying these risk factors, and the pathophysiology is significantly important. We've already seen this slide. This is, again, from our AF guidelines, looking at all of the targets that we should be aiming to reduce with respect to risk factors, and all of these are important. And this is one of the things that I've learned with respect to treatment of these risk factors is you can't treat them in isolation. They really do need to be targeted altogether, and that's critical. So I think that the main take-home message for atrial fibrillation is that it is a combined disease. It's not just an electrical disease. It really is, the atrium is a reflection of our overall health. It's one of those things that reflect basically the entire substrate that we have in terms of hypertension, sleep apnea, alcohol, exercise, and so on. And it is manifests in the final common pathway as atrial fibrillation, but it's not just targetable by just ablating. And then finally, this study was just recently presented at ERA and published in the European Heart Journal and looked at delayed AF ablation versus immediate AF ablation and showed no difference in recurrent atrial fibrillation at the end of the study at 24 months. So, and in fact, some people in the delayed group did not undergo ablation because they got better on their own. And so I think this is a very important study that we do not pursue rhythm control with haste, that we take a step back, and waiting some time is not detrimental necessarily to the patient. And again, from Dr. Andrade's study, only 7% of patients actually progress to persistent AF. So are we going to ablate this large volume of patients when it's really only 7% progressing to persistent AF compared to 2% in the ablation group with drugs? And then the atrial myopathy story, I think I've already covered, but again, important to not forget and to remember that we have to treat the entire patient. The atrium is part of the entire patient, and that there's many things that affect that atrium. And this is a terrible complication, not one of our patients, but this is a benign-looking cardomap of a patient who underwent an AF ablation, but this phlegmon was found in his left atrium after he developed an esophageal fistula. And again, these patients present too late with CT scans that look like this. It's not compatible with life, unfortunately. And so complications are important. We heard that complication rates are improving with PFA and so on, but we are probably not there yet, and we have to be very careful. And I will stop there, and we'll wait for the rebuttal. Thank you very much.
All right, Dr. Andrade, you're up for your 5 minutes of rebuttal.
So I don't really have a rebuttal. I'm just trying to think about what was said that's worth commenting on. No. That's not a negative. That's just Asperger's. So, I mean, I think that the only ones that like kind of pop out, I don't think we disagree is the first thing. Like, I think both of us are, if you asked us not in a debate forum, we would be very in tune with each other in terms of the comprehensive care. So I don't think that that is really the issue. It's just that we're kind of stuck arbitrarily debating a topic because that's what was assigned, and we have to take our position because that's what was assigned. So, on one hand, I think I approached it a little bit differently in the sense that what is my alternative? And so I don't think that there's value in delaying the inevitable, and I think that there's lots of evidence suggesting that delaying the inevitable is not going to benefit the patient. And so the thing that popped out that I can recall now is really the Kalman study. And so I don't know if anyone knows the Kalman study well, but the problem with the Kalman study is they don't know anything about the patients prior to the point that they got referred for ablation. And so this is a study about wait list management. It's not a study about delaying procedures and time from diagnosis, right? And so all they did was basically say, we'll do your procedure right away or we won't. And I find it a very helpful study in Canada where our wait lists are excessive because it's basically arguing to us that there's not much harm once you've made that decision. But the problem is that the Kalman study, a good chunk were persistent. They could have had AFib for like 7 years. They failed 10 drugs along the way. And then they get into the study. This is not early diagnosis, younger people, healthier people who you're trying to be expediting the procedure to stop the bad things. And so, the perspective that I'm arguing is we're trying to improve what we're doing by making sure that we're doing it in a timely manner so that we're not stuck behind the 8 ball by the time we get there, right? And so, yes, 7% of patients in early AF progressed, and that's a very low rate of progression, but those patients had very little comorbidities, if any. They had essentially objective measures of progression that should not have progressed, yet they did, right? And so we saw an 80% or 75% reduction in progression in early AF in a group that should not have progressed. So the fact that it was positive is almost remarkable because we wouldn't have expected that. If you look at evidence around progression, the expected rate of progression is somewhere around 7% per year when someone has paroxysmal AFib. And it's modulated by all those risk factors. And so if you're someone who's older, if you're a woman, because you tend to present with more substrate at that point, if you have other things driving it, you're going to progress much more quickly. And then so the implications of delay are much more important. Whereas if you're doing it early, you can prevent them from ever getting to that point. And so then that kind of brings me back a little bit in some of the other topics that were presented in that, again, are you going to delay the procedure just to try and optimize some of the lifestyle pieces where, again, you may optimize the lifestyle factor but never gain back what you lost by delaying the procedure, right? It's a bit of a back and forth. You're going to pull one lever and the other lever is going to go bad, or you're going to go the other way when probably you should just be doing both at the same time. I don't know if there was anything else that we needed to talk about from my perspective. But
No, I think you're done.
Okay.
Thanks very much. So I just want to raise one, thought about what was just said, and one is, progression of AF in that study. You wonder if maybe the patients who got ablated early actually, did something better for themselves. Number one, they weren't on antiarrhythmic drugs that cause side effects. We know antiarrhythmic drugs cause side effects. I mean, they make people feel terrible, and so you wonder if the people who were ablated just were doing more and were healthier and more active and doing all those things that we think are good for the atrium, and maybe that prevented progression and wasn't necessarily the ablation. So just to think about that there may be other things at play that we don't measure in clinical trials that may be actually influencing what we're seeing. And so, I just I don't really have a rebuttal per se either, except to think more about what we're doing to our patients. I wanted to make a couple of points before we ended. One is that we can't just focus on one risk factor. We need to do it multimodal, and that is why I like to answer questions. I like to get evidence, and I like to have evidence that's strong. And so that's why we're doing this study, which is a reversal of atrial substrate to prevent atrial fibrillation study, where we're looking at vigorous treatment of atrial fibrillation with risk factor modification upstream to the ablation, randomized to standard of care with ablation. So, I'm a strong believer in ablation, there's no doubt about that, but I really do think that we need to treat the entire patient first. I'm hoping that this study is positive, and if anybody would like to be part of it, I welcome everyone to be part of the study. I think it's going to help us answer these questions that we've raised today, and hopefully put the nail in the coffin on this and do this for our patients well. Thank you very much.
So before we open it up for questions and additional rebuttals, can you just bring up my slides, please? I just have, and can we, yeah. So I was just curious with a show of hands, who would say AF ablation, the sooner is better? Okay, that's about half. And then fix the risk factors first. Yeah, I would say it's half-half, so great job. You guys convinced nobody of your arguments.
Didn't ask us.
All right, well, we can open this session up for questions. Do you want to just go to the mic, please?
All right. So that is a fascinating debate with two people I know very well. So my point is, I think both are right, because what Jason is saying is early ablation is a risk factor modification. I mean, these people are at risk of triggered activity, remodeling their atrium. So you have to institute, risk factor modification, one of which includes early ablation. Is that a fair summation?
I don't know. I didn't put it in this slide, but one of the things that I talk about with patients is this. So if you look in the AF guidelines where it talks about, the relative balance of triggers versus substrate, and then there's these three colors and things. And so when we do the procedure on follow-up, I'll bring up this slide, I'll put it on the screen, I'll say, okay, look, this red triangle of relative importance that gets bigger as we get to progression, well, that's not modifiable risk factor, so none of us can do anything about that. This orange wedge that's driving the progression to persistent AFib, that's your AFib-induced change. My job is to deal with that, and we've done the ablation, and so we've kind of fixed that piece. This giant green wedge that's left in the middle, that's your blood pressure, your body weight, your exercise, and all those things. And if you don't make an effort to fix those things, the AFib is going to come back over time, because then you're just leaving it in the background. Like, I don't have some magical thing that fixes everything. I can deal with part of the problem, and part of the problem is dealing with the arrhythmia, and a substantial amount is the risk factors. And this is why I say at the very beginning, we don't do these things in isolation. We do everything together, and in doing everything together, that's how we realize the best outcome. And so you need to change the risk factors. You need to do everything you can to reduce what's happening in the background, because the very late recurrences are usually not PV reconnection or something along those lines. It's something that was festering in the background for 5 years that all of a sudden, you go and do the second procedure and it doesn't look anything like it did at the first, and it's because nothing changed. And so I believe it's true that we have to be very aggressive in the risk factors, and we have to modify the substrate by modifying the comprehensive cardiovascular care of that patient.
Sorry, I would just, not forget about the point that that there are a large proportion of patients that would respond well to some of the risk factor modification initially and obviate the need for ablation. I mean, we may not see those patients because they may not even get to us. So we have a very biased view of AF as electrophysiologists, because we're not seeing all of AF. We're not seeing 300,000 patients as a group of 200 electrophysiologists in the country. It's not possible. So there's a huge amount of AF out there that we don't have any part of. We're seeing the cream of the cream for patients that are coming to us with the most symptoms, and so that's probably why half the room is interested in the ablation, because that is what we can offer them as EP. But to jump right into that and not to address these other things, I think might be disservicing some of our patients and ablating people unnecessarily in the long run. But it remains to be seen. Maybe the ablation is the first critical step, and the other things you can't address unless the ablation is addressed. So just to think broadly about that.
Hey, so I was wondering about the healthy adherer effect was pretty cool, and I'm struck by the also agree with Radhika, it's impossible to ablate all AF patients. So is the healthy adherer effect, so like it or not, as electrophysiologists, we're going to have to be assessing futility of AF ablation in patients. And then would the healthy adherer effect, a kind of run-in phase for a patient with a BMI of 39, proving that they can get to 36, is that going to be a good way of saying that this is not futile in this very obese patient? So despite the lack of randomization of that data, is it still useful when we're making our ablation decisions?
I'm trying to think about, you had two things and how I want to frame it. So the first thing is that we do very little ablation in Canada in general compared to other geographies. And so, the amount of patients that get to the point of getting ablation is very low, generally speaking. I don't think anyone is aiming to ablate everyone. I don't think anyone in the room is aiming to ablate the majority even of people, right? I mean, the whole point is that I think as a community, we want to appropriately select out the people who have the most to gain and the least to lose from an invasive option, irrespective. We tend to historically see the people who have no other options, right? Because they've already gone through whatever else that got them to our door. And at that point, we have limited alternatives, right? They've failed antiarrhythmic drugs. Presumably somewhere along the way, someone has attempted to make their lifestyle modifications and lifestyle changes. I don't think we ever see, or we very rarely see, completely de novo people who have never had any healthcare contact prior to showing up in an electrophysiologist's office for an ablation. So yes, we do see the cream of the crop, but there's a reason why they get selected to come to us. I think that the message from my perspective is we don't want to miss an opportunity with things that aren't necessarily going to have benefits in the long run. I guess the other comment there was the concept of futility, and I think that needs a lot more exploration, because how we have conceptualized arrhythmia management is not necessarily, I don't want to say appropriate, but I don't think we've been thinking about it in the right way, right? So for example, if you look at sort of vanilla Castle as a study, so not the one that was just presented a couple of weeks ago, we've always focused on the Kaplan-Meier curves. We've always focused on the concept of cure. We've always looked at it as 70% success or whatever. But that's not really giving us the answer. And if you look at the mortality benefit in Castle, how much AF you had to sort of debulk or reduce, it's not about cure, it's not about elimination, it is a gradation of effect to show improvement and benefit for that patient. And so do I really want to ablate people with BMIs of high 30s and or into the 40s? No, I have no desire to do that. Am I going to be very trepidatious about that when they come to my office? Of course I am. But at the same time, some of these people, they can't exercise because their AF is limiting. They are stuck in a place where no matter what's happening, they can't make the improvements that they have. So we need to meet people where they are, and we need to enable them to be successful in whatever approach they want, and that's where we get into an individualized conversation. For me, the message that's important is not to discount people early and not to spend forever doing nothing, so that by the time people come to us, they're so far behind the 8 ball that our success is going to be limited by delay and inaction. And so, do we need to have comprehensive risk factor modification and supports? Of course we do. In BC, we have that in 5 places in a province of 5 million. Clearly, we are not touching everyone that we should touch in terms of improving their lifestyle. And I'm not even talking about ablation. I'm just talking about comprehensive care for their AF. So yes, we have a lot of changes that we need to do. Healthy adherer effect is there. It's people who are committed to improving their quality of life and everything else are going to do better than people who are not. Does that mean we just basically discount everyone and send them away? No, because you wouldn't do that if someone smoked. You wouldn't fire them from your practice because they're a smoker. It's unethical as a clinician. So we have to look at the comorbidities and the commitment people have and support them as best we can.
I agree. Actually, I think that was framed very nicely. So I think, we're saying the same thing. It's just maybe there's some timing issues that are slightly different. But in Canada, the reality of the matter is that we have timing issues that are imposed upon us that have nothing to do with what we think is the right thing to do for the patient. We have these wait lists and unfortunately, the wait lists sometimes are ahead of when they get to see an EP. They're out in the community becoming persistent before they even get to us. So we have some real issues in Canada to try to improve AF overall. But I agree. I don't have anything to add there. And I think the healthy adherer effect is real. There is behavior and that's the problem with the trial, even in RASTA, where we're trying to affect behaviors. It's very difficult to do behavior modification. And as much as we're trying to standardize it in that trial, the behavior is going to come out. There's a lot of noise when you do a behavior modification type trial. And so we have a very large sample size for that reason, to try to drown out the noise and actually come up with what's the real effect of affecting these risk factors.